Welcome back to the deep dive. Today, we are shifting gears. We're putting on the scrubs, scrubbing in, and walking directly into the operating theater. We are tackling a subject that I think scares even seasoned registrars. We are opening up the heavy artillery of surgical textbooks, Baily and Love's Short Practice of Surgery, the 28th edition.
A classic.
Yeah.
It really is the foundation for so many surgical careers. If you haven't held a copy, you haven't really started your surgical rotation.
And we aren't just, reading the preface or the general principles today. We are zooming in on Chapter 91, Intestinal and Multivisceral Transplantation.
Right.
Now, to set the stage here, when I first looked at this chapter, I expected just another section on plumbing, sewing tube A to tube B. But that is not what this is. This feels more like the Mount Everest of abdominal surgery.
That is the perfect analogy. It really is. It's the final frontier. You have to understand, we conquered the kidney decades ago. The liver, we've gotten very good at. But the intestine fights back.
Why is that? What makes the gut so much harder to transplant than, say, a kidney?
Well, there are two main reasons, really. First, it is an immunologically angry organ.
Angry.
Yeah, angry.
Yeah.
It is loaded with lymphoid tissue pairs, patches, lymph nodes, the whole mesenteric complex. I mean, its whole job is to recognize enemies because it deals with bacteria all day long. So when you put a donor gut into a recipient, that immune system just wakes up immediately.
Okay, so it's primed for a fight.
And second, it's incredibly intolerant of ischemia. It cannot survive without blood flow for very long at all.
So you have an organ that dies quickly if you don't hurry and then tries to kill you or, gets killed by your immune system once it's in.
It's a high wire act, a real balancing act.
Before we start our ascent to this Everest, let's be really clear about our mission today. We are distilling Chapter 91 into a revision aid, a sort of ready reckoner for the medical learners listening. We are the tour guides. Baily and Love is the territory. We want you to understand the framework so when you actually read the text, it sticks.
Correct. And please do not skip the actual chapter. There are diagrams in there, vascular maps and decision trees that you need to see them with your own eyes.
Yeah.
But we'll give you the narrative structure and the hooks to hang that information on.
Okay, so let's break this down, maybe into 4 main courses to keep it organized. First, the indications. The tragedy of intestinal failure.
Why?
The why. Second, the menu. The specific types of transplants available. Third, the procedure. The whole concept of the hostile abdomen. And finally, the aftermath, the immunology and complications.
Sounds like a solid plan.
Let's start with that why. Why do we even do this? The core concept is intestinal failure. So the gut can't absorb nutrients or fluids, but we have a solution for that, right? Parenteral nutrition DAF PN, we can feed people through their veins. It works.
It does work. PN is a medical miracle. I mean, it keeps people alive who would have starved to death 40, 50 years ago. But you have to view PN as a bridge. For many, it's a bridge to recovery or a manageable life. But for some, that bridge starts to crumble.
And this is the crux of it, isn't it? The indication for transplant is almost entirely defined by the failure of PN.
That's it.
It's not just, I have short bowel syndrome. It's, I have short bowel syndrome and the PN is killing me.
Precisely. Baily and Love list the big 3 complications of PN that trigger a transplant assessment. If you are sitting exams, you need to know these cold.
Okay, let's unpack them one by one. Number 1 is IFOLD.
IFOLD, intestinal failure-associated liver disease. It's a biochemical tragedy, really. The lipid emulsions in the PN feed the fats. They're cleared by the liver. And over months and years, especially in children or people with the very short guts who have bacterial overgrowth, those lipids become toxic.
Toxic how? Is it just like clogging things up?
It causes cholestasis, so the bile stops flowing properly. Then you get inflammation, then fibrosis, scarring, and then eventually frank cirrhosis. The liver becomes rock hard and it fails.
And the text is very specific here regarding assessment. You can't just guess based on blood work.
No, absolutely not. You need the biochemistry, yes, but often you need a liver biopsy. You have to know the architecture. Is it just a bit of scarring? Or is it full-blown cirrhosis? Because that decision changes the entire surgery.
How so?
Well, if the liver is gone, you have to replace the liver and the gut. It's a much bigger operation.
Okay, so failure mode 1, the liver fails. Now failure mode 2, loss of access.
This is a plumbing problem.
Yeah.
A pure and simple plumbing problem.
Yeah.
To deliver PN, you need a high-flow central vein.
Yeah.
Usually the superior vena cava, via the jugular or subclavian veins.
Yeah.
But any foreign body in a vein, it causes clots. They get thrombosed. They shut down.
And we only have a finite number of these veins. It's not like peripheral veins where you can just find another spot on the arm.
Exactly. In an adult, you essentially have 4 primary highways.
Yep.
2 internal jugulars and 2 subclavians. If you lose access to 3 of those in an adult, or 2 in a child, you are in the danger zone. You are literally running out of places to plug in the life support.
That is a terrifying thought. You have the fuel, but nowhere to put it. And the third one?
Sepsis. But, not just, I had a fever once. We are talking about recurrent, life-threatening, catheter-loaded bloodstream infections.
Okay.
And Baily and Love specifically flags fungal infections here.
Fungal specifically. Why does the book highlight that? What's special about fungus?
Fungi like Candida are incredibly hard to clear from lines, and they often signal that the patient's whole microbiome is totally disordered.
Right.
If you are getting repeated septic shock, despite really good catheter care, the PN has become a liability. The line that is feeding you is also poisoning you.
So, the big 3. IFALD, loss of access, sepsis. Those are the life or death triggers. But the chapter also mentions a shifting goalpost. Quality of life.
Yeah, and this is controversial, but it's a growing area. Being tethered to a pump for 16 hours a day is a massive burden. You've got high-output stomas, constant dehydration, inability to work or go to school. We are starting to see transplants considered for patients who are medically stable on paper, but whose lives are essentially unlivable because of the therapy.
Right. Before we move off indications, we should probably touch on the anatomy. It's not always just that the gut doesn't work. Sometimes there are things growing in there that shouldn't be.
Right. The structural or anatomical indications. And desmoid tumors are the classic exam answer here.
What exactly is a desmoid tumor?
It's a locally aggressive tumor of the connective tissue in the mesentery. That's the sheet of tissue that holds the bowel and its blood supply. It doesn't usually metastasize like cancer, but it grows and it wraps around the major blood vessels of the gut like concrete.
So you can't cut it out?
You can't cut it out without cutting the blood supply to the entire intestine. So the only way to remove the tumor is to remove the whole gut with it.
That's a radical solution.
Yeah.
But if it's strangling the blood supply, you have no choice.
Exactly. You also have what are called acute vascular catastrophes.
Yeah.
A sudden clot in the superior mesenteric artery, the SMA, or a volvulus, a twist, that kills the entire midgut in hours.
Let's just pause for a quick sidebar on demographics here. The causes of short bowel syndrome, or SBS, they're different for adults and kids, aren't they?
Very different. If you see a pediatric case, you should be thinking congenital. Gastroschisis, where the gut is born outside the body. Volvulus, or necrotizing enterocolitis, NEC, in premature babies.
And adults.
Think acquired.
Mm-hmm.
Mesenteric ischemia, that clot we mentioned. Crohn's disease, where they've had surgery after surgery until there's almost nothing left. Or, massive trauma.
Okay, listener, let's do a quick check-in. This is a lot of information, so let's consolidate. Mental pause. Can you name the 3 failure of PN criteria that trigger a transplant assessment?
Think about the organ that processes the fat, the veins you use to deliver it, and the bugs that can crawl down the line.
Got them. It's IFALD, the liver disease, loss of access, no veins left, and sepsis, recurrent or fungal.
Yeah.
If you didn't get those, just pause and rewind. You really need to lock them in. Those are the high yield points for your exams.
Absolutely essential. Without those criteria, you don't even start the conversation about transplant.
Okay, moving on to section 2, the menu. This is where the terminology in the chapter gets a little dense. Multivisceral, modified multivisceral, cluster. Let's try and simplify this. I like to think of this as ordering a combo meal at a fast food joint.
Huh, that works perfectly. It's modular surgery. You take what you need.
Baily and Love Table 91.2 breaks this down. Let's start with the simplest order. Item 1, isolated small bowel.
Just the intestine. This is for the patient whose liver is still working. Remember we talked about IFALD. If that liver biopsy shows only mild fibrosis, you don't need to replace the liver.
Why not? I mean, won't the fibrosis just get worse?
No, and this is the really fascinating part. The liver damage is driven by the PN. Once you do the transplant and stop the PN, that mild fibrosis can actually reverse. The liver heals itself.
That is incredible. So if you catch it early enough, you save the patient's own liver.
Exactly. And you spare them the risk of a liver transplant, it's huge.
Okay, item 2, liver and small bowel. This is the standard combo, I guess.
This is for when the PN has wrecked the liver. You've got cirrhosis or severe, what we call bridging fibrosis. You cannot leave that liver in. It will fail. So you take the donor's liver and small bowel en bloc connected together and transplant them as a single unit.
Now we get to the heavy hitters. Item 3, the multivisceral transplant. the whole enchilada.
This is a massive, massive operation. You're replacing the stomach, the duodenum, the pancreas, the spleen, the liver, and the small intestine. Sometimes part of the colon, too.
Why on earth would you need to do all that? Why take the stomach and pancreas if they aren't broken?
It usually comes down to blood flow. Imagine a patient who has widespread thrombosis clotting in the portomesenteric venous system. That's the entire network of veins draining the stomach, pancreas, and gut into the liver.
Okay.
If all those veins are clotted solid, you can't just sew a new gut in. There's no plumbing to drain the blood away.
So you have to rip out the entire drainage basin and just replace it.
Exactly that. Or for those extensive tumors we mentioned, like desmoids, where the tumor has frozen all those organs together into a single concrete block, you have to take them all out to get clear margins.
And finally, item 4, the modified multivisceral. This is the hold the liver order.
Right. It's the stomach, pancreas, and intestine, but without the liver. You keep your own liver.
And when would you use that?
It's pretty rare. You might see it in patients with that diffuse thrombosis of the gut veins who still have a pristine liver and patent hepatic veins. Or in widespread motility disorders, like chronic intestinal pseudo-obstruction, where the stomach and gut just don't move, but the liver itself is fine.
So the pivot point for all these decisions, it really seems to be the liver.
The liver is the anchor, absolutely. That's why the assessment phase involves a massive multidisciplinary team, an MDT. You need a hepatologist to stare at that biopsy slide. You need radiologists to do detailed vascular mapping. You have to ask 2 questions. Can we plug this in? And do we need a liver?
And there's a psychological component too, right? We shouldn't gloss over that.
Oh, huge. This is a life-changing trade. You are trading one chronic illness management PN for a completely different chronic illness management. Immunosuppression, regular biopsies, constant fear of rejection. The patient has to be psychologically robust enough to handle that regime.
Let's move to section 3, the operation. Baily and Love uses a very evocative phrase here to describe the recipient's abdomen. They call it the hostile abdomen.
It is a great term. It paints the picture perfectly.
What makes it so hostile? Is it just inflammation?
It's scar tissue.
Yeah.
I mean, you have to remember, these patients haven't just arrived fresh. They have often had 10, maybe 20 surgeries before this, resections for Crohn's, stoma formations, line insertions, hernia repairs. The abdomen is just full of dense scar tissue. The organs are stuck together. The planes you usually dissect, they're gone.
So just getting the old organs out the explant is a battle in itself.
It is technically very difficult and very bloody. You risk damaging the retroperitoneum or the major vessels just trying to clear the space. It's like excavating concrete. Baily and Love mentions that sometimes preoperative embolization of the vessels can help reduce bleeding, but it is always a major challenge.
Okay, now let's talk about the donor side. This isn't like a kidney where you can have a living donor. I mean, technically, living donor bowel transplant exists, but it's vanishingly rare, right?
Correct. For all intents and purposes, we are talking about deceased, brain-dead donors, and there's a time bomb ticking.
We mentioned ischemia earlier. How long do you have?
The cold ischemia time, that's the time from when the donor's heart stops and the organ is cooled to the moment blood flows back in the recipient. It needs to be less than 6 hours.
6 hours. That's nothing. A kidney can wait 24 hours, a liver maybe 12?
The intestine is metabolic dynamite. The mucosal lining, the inside layer, it starts to slough off very, very quickly without oxygen. If you wait too long, you transplant a dead organ, and the patient dies of sepsis almost immediately.
So this requires incredible logistics. The donor surgery and the recipient surgery are basically happening at the same time.
Yes. You are cutting the recipient open while the retrieval team is still in the donor hospital or literally on the helicopter. You have to time it perfectly so the hole is ready just as the organ arrives.
Let's visualize the plumbing, the anastomosis. How do you actually hook this thing up? The book mentions something called a Carroll patch. Can we explain that for someone who might not have seen one?
Sure. Imagine the main artery feeding the donor gut is the superior mesenteric artery, the SMA. It's a tube, maybe 6 to 8 millimeters wide, but you don't just cut the SMA and try to sew that end to end. It's too prone to narrowing to stenosis.
So what do you do instead?
When you take the organ from the donor, you take a patch of their main aorta around the base of the SMA. It's like a button of aortic wall.
Like cutting a circle of drywall out along with the pipe that's sticking through it?
That's the perfect analogy. Then you sew that big button onto the side of the recipient's aorta. It's much safer, less likely to clot, and it allows for much better flow. And this is usually done on the infrarenal aorta, so below the kidneys.
Okay, that's the inflow. What about the outflow, the venous drainage?
Well, this depends on the combo meal you ordered. If you are transplanting a liver and bowel together, the blood drains through the donor liver into the donor vena cava. So you just hook up the vena cava. That's big, easy plumbing.
But if you are not transplanting a liver, if it's just the intestine,
then you have a real challenge. You have to drain that donor vein into the recipient's portal vein so it can go to their own liver. That is technically much harder because the recipient's portal vein might be scarred or retracted or just difficult to reach behind the pancreas.
and once it's all plumbed in, that moment of reperfusion, when you take the clamps off, that must be a tense moment.
It's the moment of truth. You watch the gut turn from a pale gray to pink, but you're also watching the patient's blood pressure like a hawk because you are flushing cold, potassium-rich fluid from the organ straight into their heart. The anesthetist has to be on their game.
Yeah, they usually leave a stoma, right? Even if they connect the bowel in continuity.
Yes, almost always. A chimney ileostomy. And this isn't primarily for, poop, though it does that. It's a window. It's a viewing portal. It allows the team to stick an endoscope in easily and take biopsies because, as we'll discuss, you need to watch this graft like a hawk.
I want to touch on one more surgical aspect that I found fascinating, and that's abdominal closure. You've put this new, possibly swollen organ into a hostile abdomen that might have shrunk because it was empty for so long. It's like trying to close an overpacked suitcase.
Loss of domain is the technical term for it. And you're right, if you just pull that zipper too tight, if you suture the muscles closed under tension, you get compartment syndrome. You crush the renal veins, you crush the new gut, and you kill the graft.
So what are the options? Just leave it open.
Sometimes you leave the skin open and close it slowly over weps. But Baily and Love mentions a really brilliant innovation, transplanting the abdominal wall.
Wait, you mean actual skin and muscle?
Sometimes a full vascularized wall, skin, muscle, fascia, fed by the epigastric vessels. But more commonly, they use the donor's rectus sheath, the tough fascia that covers the six-pack muscle. They strip the muscle off and use just that fascia as a biological mesh.
Why is that better than a synthetic mesh?
Because it's biological tissue. It vascularizes. Blood vessels actually grow into it. It becomes part of the body. A synthetic mesh in an immunosuppressed patient is just a magnet for infection. This biological fascia integrates. It's really elegant.
That is incredibly cool. Okay, the organ is in, the abdomen is closed, hopefully. Yeah. Now we enter section 4. The danger zone, the complications.
This is where the battle's really fought. The surgery is just the opening shot.
Let's create a fictional patient here to make this concrete. Let's call him Mr. S. He's 3 days post-op from an isolated small bowel transplant. Suddenly, he spikes a fever. What is going through your mind?
Panic. Controlled panic. But analytically, at 3 days, I'm thinking about 2 main surgical disasters: thrombosis and leaks.
Thrombosis meaning a clot.
Yes. These patients are often prothrombotic. Their clotting system is all over the place. If the artery clots, the graft dies in hours. If the vein clots, the graft swells up, turns purple, and dies. So they are on anticoagulation, but that balances against the risk of bleeding into that fresh surgical site. It's a very fine tightrope.
And leaks.
And anastomotic leaks. If you've connected the stomach or esophagus in a multivisceral transplant, those are really high risk. An esophageal leak in an immunosuppressed patient is an absolute catastrophe. It causes mediastinitis.
And the book mentions a specific innovation for treating these leaks without having to cut them open again, the endovac.
Yes. Instead of rushing back to surgery, which puts huge stress on the patient, you put a sponge on a tube down the throat, place it into the leak cavity, and apply suction. It cleans the cavity, and it physically sucks the walls of the hole together to help it heal. It has really revolutionized the management of these leaks.
Okay, so let's say Mr. S survives that first week. Now we enter the realm of immunology. You said earlier the gut is angry.
It is the largest immune organ in the body. When you transplant it, you are transplanting billions of donor lymphocytes. And this leads to a double-edged sword: rejection, where the host is fighting the graft, and GVHD, where the graft is fighting the host.
Let's start with rejection. Baily and Love says it happens here more than any other organ. How do you spot it?
It's subtle. It usually starts in the terminal ileum, which is why that chimney stoma is so critical. You can scope right in there. The clinical signs are increased stoma output, diarrhea, and fever.
Wait a second. Increased output, diarrhea, fever. That sounds exactly like gastroenteritis or sepsis.
And that is the trap. In an intestinal transplant, rejection often mimics sepsis. And what's worse, rejection causes sepsis.
Walk us through that mechanism. This seems like the most critical concept for a learner to grasp.
Okay, so rejection attacks the lining of the gut, the mucosa. It destroys the villi. Now, the mucosa is the only barrier keeping the trillions of bacteria in your poop away from your blood. When rejection destroys that barrier, the bacteria cross over. This is called translocation.
So the patient gets septic because they are rejecting.
Precisely. So if you see a patient with fever and high stoma output, you cannot just say, oh, it's an infection and give antibiotics. You have to assume it is rejection and sepsis. You treat the infection, but you rush for a biopsy to confirm rejection so you can hit it with high-dose steroids.
And if you miss the rejection because you thought it was just a bug,
the graft dies.
And likely the patient, too.
Mm-hmm.
Okay, check-in question 2 for the listener. If your intestinal transplant patient has high stoma output and a fever, what 2 processes are likely happening simultaneously?
Think about that barrier breaking down.
It's rejection causing sepsis. You have to treat both tracks at the same time.
Correct. Do not be reassured by a positive blood culture. It might be a positive culture because the gut wall is dissolving from rejection.
What about the long-term scares? The chapter highlights PTLD.
Post-transplant lymphoproliferative disease. This is a type of lymphoma, a cancer of the B cells, and it's driven by the Epstein-Barr virus, EBV.
The glandular fever virus.
Yes. Most of us have it dormant in our bodies. But because we have to suppress the immune system so heavily to stop that angry gut from rejecting, the body keeps the T cells asleep. The T cells are what usually keep the EBV in check. Without them, the EBV wakes up, causes the B cells to go crazy, and you get lymphoma.
The rate mentioned is staggering up to 17% in some series. That is almost 1 in 5 patients.
It is very high, and it presents a terrible, terrible dilemma. To treat the cancer, the first step is to lower the immunosuppression so the body can fight the virus. But if you lower the immunosuppression...
the graft rejects.
Exactly. You are stuck between cancer and organ failure. It is a very, very difficult tightrope to walk.
And then there is the reverse problem. GVHD, graft versus host disease.
This is where the donor's immune cells, the ones in the lymphoid tissue of the transplanted gut, wake up, look around, and say, everything here is foreign. And they attack the patient.
What does that look like?
A rash on the skin, liver dysfunction, and critically bone marrow suppression. If it hits the bone marrow, it wipes out the patient's own blood cells. It is almost universally fatal in the context of bowel transplant.
That is a very sobering list of complications. But let's zoom out to section 5. Outcomes. It's not all doom and gloom, is it?
No, it's actually getting much better. The chapter highlights that for intestine-only transplants, the 1-year survival is now over 80%.
And that's comparable to the survival of patients who are staying on long-term PN, but who have those complications.
It is. The lines have crossed. The risk of the surgery is finally balancing out with the risk of staying on the pump.
And for liver-containing grafts.
It's over 70%. And it's improving because we are getting better at balancing that immunosuppression. We're better at using PCR to spot viruses like EBV early, and we're using things like the Endovac to manage leaks.
But there is an Achilles heel mentioned in the long term, and that's renal failure.
Yes. The kidneys take a real beating. First, the drug tacrolimus, which is the cornerstone of anti-rejection, is directly toxic to kidneys. It's nephrotoxic. Second, if you have a high-output stoma, you are chronically dehydrated. Third, just the stress of the surgery itself.
So you save the gut, but 5 years later, they need a kidney transplant.
It happens. Many of these patients end up on dialysis or eventually needing a kidney graft. It's a systemic trade-off.
So bringing it all together, what is the golden rule of Chapter 91? If the listener remembers just one thing about the management of these patients, what should it be?
The golden rule is, sepsis is the main killer, but rejection pulls the trigger. You have to manage the immune system perfectly. Too much suppression gives you PTLD and infection. Too little gives you rejection and sepsis. Balance is everything.
Okay, let's wrap this deep dive up. We've covered a massive amount of ground here.
We really have.
Let's just recap the critical concepts for your revision notes.
It's all about the failure of PN. Look for the big 3. IFALD, liver failure needing biopsy, loss of access, running out of veins, and sepsis, especially fungal. 2, the surgery. It's a race against time less than 6 hours of cold ischemia. You use a Carroll patch on the aorta to prevent thrombosis, and you might need to deal with a hostile abdomen by using the donor fascia to close it.
Right.
And 3, complications. Rejection starts in the terminal ileum. It causes barrier breakdown and sepsis. Watch for high stoma output. And watch out for PTLD caused by EBV.
Perfect summary.
So here's a final provocative thought to leave you with. The chapter mentions that quality of life is a growing indication. We are now seeing survival rates that are starting to match complicated PN. Are we moving toward a future where intestinal transplant is as common as, say, kidney transplant?
It's a fascinating question. Right now, a kidney transplant is the gold standard. It's much better than dialysis. Intestinal transplant isn't quite the gold standard over PN yet because of all the high risks we've just discussed, but the gap is closing. If we can solve the rejection puzzle, maybe with stem cells or better tolerance induction, then maybe one day the short gut patient won't have to be tethered to a pump at all.
A hopeful note to end on. Okay, listener, your call to action is simple. Open Baily and Love, Chapter 91. Look at Figure 91.1. That's the diagrams of the different cluster transplants. Visualize the plumbing we talked about. And look at Table 91.1 for the specific criteria for PN failure.
Seeing the anatomy really helps lock it all in.
Thanks for joining us on this revision session. Good luck with your studies, and we'll see you on the next Deep Dive.